genitals is like our eyes. Will you put anything in the eyes easily? So similarly, it's also tender. So don't apply anything without the knowledge of doctor, without the guidance of doctor. Good morning, everybody. Thank you, the organizing committee, for giving me this opportunity to share my view about the genital manifestations. Anything over genitals will affect sexuality of the individual, whether man or woman, whether it is a inflammation, trauma, tumor, bleeding, any itching, everything will one way or other it will affect the sexuality and sexual practice. Maybe pain, maybe due to fear, maybe due to passing the infection to others. So many ways it may affect. Among these genital manifestations, Balanoposthitis and Vulvovaginitis are the commonest one. Every one of us, when you are recognized as a sexual medicine practitioner, you will not be avoiding this type of things, and it will be the most common thing will be presenting in your practice. Sometimes or many times you will have confusion how to diagnose, how to treat. Let us discuss something now. So Balanoposthitis, balanitis means inflammation of the glans penis, posthitis means inflammation of the prepuce. Usually it will be together. So because of that it is called as Balanoposthitis. Similarly, Vulvovaginitis. So regarding this Balanoposthitis, I am going to discuss etiology, clinical manifestations, investigations, diagnosis, predisposing factors and management. I told already Balanoposthitis, and etiology for Balanoposthitis, it could be due to infection, inflammation, irritant, secondary to trauma sometimes may appear as a balanitis, and fixed drug eruption. So one of the commonest problem, exposure to certain drugs will cause lesions over the genitals alone, or sometimes maybe elsewhere also. Fixed, why it is called as fixed drug? Even whenever you are exposed to this particular drug, the same sites will be affected. So that is called as fixed drug eruption. And pre-malignant conditions, certain pre-malignant conditions, malignancy, non-venereal dermatological conditions, and miscellaneous. The commonest thing is fungus, especially Candida. Candida, there are many types of Candida are there. Candida albicans is the commonest one. Sometimes non-Candida also may be there. Non-Candida, you may have to opt for other normal treatment may not be effective. Irritant Balanoposthitis, accumulation of dirt, soap material or uncleaned smegma. So this is very common. We are teaching our children how to brush their teeth. We are teaching our children how to take bath. Nobody teaches our children how to care their genitals. It has to be. No, majority of the individuals, especially men, at the age of 60 even, never try to retract the prepuce even. It may not be phimotic. They never try to retract the prepuce, never see the coronal sulcus even, not even once. So it has to be cleaned daily. So that has to be done. So the smegma is a sebaceous, modified sebaceous gland. When it is left uncleaned, it may irritate. And chemicals like podophile, various types of chemicals which we are using to treat some other things may irritate. And pain bombs, accidentally or unknowingly, anything available, it may be applied to genitals. So that pain bombs or irritant topical applications vaginal spermicides, lubricants, and condoms. Condoms also sometimes may cause allergy. So the irritant balanoposthitis. So it is a first slide is a child, another is other adults. So all these things are application, local application. Majority of them don't want to go to doctors. Whichever is available in the hand, whichever is available in the house, they may apply. So all these things may produce. And in that the skin will be not only scaly, irritant, but also edematous. And other cases of irritant balanoposthitis, see the redness and other things shrinking. So all these things can happen. So you have to understand and not to teach the patient not to put unnecessarily all the things. Genitals is like our eyes. Will you put anything in the eyes easily? So similarly, it's also tender. So don't apply anything without the knowledge of doctor, without the guidance of doctor. So that is the thing I want to convey. And also, when it is withdraw this drug offender and apply some steroid, if necessary, if it is severe, you have to give oral steroids also. It will be, the patient will be all right. And secondary to trauma, sometimes it may mimic. It's not a really balanoposthitis, maybe due to aberration, sexual aberration, or masturbation aberration, zip injury, road track accidents, and friction injuries. Friction injuries also may look like that. So teeth bite. So all these things may look like it's not a balanoposthitis. And fixed drug eruption I told already. So fixed drug eruption, how to diagnose? So this is commonly it's for sulfa drug, NSAID, all the painkillers, and sometimes even for the antibiotics and ofloxacin, the fluoxetine, all these things, any drug, even metronidazole. But most commonly sulfa, Septron, and NSAID is common. So here it will be localized. There may be bulla, there may be a violaceous disc. You can see a violaceous or dark pigmentation. So that is more characteristic for fixed drug eruption. Sometimes it may be raw area, and even this raw area you can see the second slide, you can see here some darkness. So this type of darkness and violaceous things, it may be indicative of fixed drug eruption. You have to elicit the history, any history of drug exposure. So that will give a clue. And important, not only treating the patient, so you have to pick up that what is the drug, usually possible drug, and label this drug not to be exposed here afterwards. So that is very important. Otherwise, the same site will be involved. Sometimes, if in repeated exposure, the multiple sites may be involved, and the same site will be enlarging also. That is the thing. And on healing also, it will leave a violaceous pigment, which is not irritating, which is not itching or anything. But the pigmentation will leave for many, even months or years, even especially in other places. That's also we have to keep it in mind. And fixed drug eruption with secondary infection also, if it is not attended properly. Pre-malignant conditions. What are the pre-malignant conditions? Erythroplasia of Edquartet, Bowen's disease of penis, extra-mammary Paget's disease, leukoplakia. All these things can occur in genitals. Erythroplasia Edquartet and plasma cell balanitis of Zoom both are more or less similar, affecting the local area. Rest of the penis will be normal. In fungal infection, other things, the rest of the whole area will be affected. Or some area it may be severe, some area it may not be severe. Here it is a localized. The erythroplasia Edquartet, it will be more reddish and slightly velvety appearance, raised and velvety appearance. In Zoon's balanitis, there will be an orange tinge will be there, and biopsy will be confirmed. So both of these things are mostly due to smegma irritation. Circumcision will be helpful. Even without circumcision, if you insist for repeated washing, proper washing, usually washing, I usually advise plain water, not necessary to use soap. So that will do good, frequent washing. And sometimes we may need steroid application or circumcision at the end. So this is malignancy, squamous cell carcinoma. This is also not uncommon, especially in an individual who is having congenital phimosis or left unretracted for years together. The smegma is one of the cause for cervical, that is perineal cancer and cervical cancer, and also human papillomavirus infection also may lead to, and most of the 3 million conditions, so many other things, leukoplakia or some other things may end in squamous cell carcinoma. And cutaneous, various cutaneous manifestations also may manifest as balanoposthitis, but here most of the time the patient will have lesions elsewhere in the body also. Pemphigus vulgaris, a bullous eruption, vesiculobullous eruption, and dermatitis herpetiformis is another bullous eruption. Erythema multiforme, Stevens-Johnson syndrome is a drug allergy, extensive drug allergy, almost all the body, 10 toxic erythroplasia, that is also. So all these things due to drugs and may involve elsewhere in the body. Behçet disease, so another thing, usually it will be ulcers, oral ulcers and genital ulcers may be there. After, like in mouth, sometimes individual may have aphthous ulcer without anything, a yellow necrotic ulcer, multiple ulcers may be present in the genitals also. If you rule out all the other things, you can think of the aphthous ulcer. Herpes zoster in the area of genitals, and it may involve, but it's also not only herpes genitals is confined only to genitals, but herpes zoster, it will involve the course of the nerve and it will be painful and burning sensation. Varicella, you can see lesions elsewhere also. Secondary syphilitic lesion is once again, secondary syphilitic lesion, patient may have body lesion, lymph node involvement, and especially in genitals, it may erosions. These erosive lesions may look like balanoposthitis. So see, this is erosive lesion. This type of erosive lesion, both in men and women, is not uncommon in secondary syphilis, and this we have to do syphilitic serology and confirm, and you have to treat the syphilis, it will be okay. And Foreman's balanitis of syphilis, this is an unusual presentation in syphilis. You can demonstrate the organism from this Treponema pallidum in the dark field microscopy. So this is very uncommon. So this is one of the manifestations of syphilis also, but not in secondary syphilis. Only manifestation of primary syphilis like that. Secondary syphilis is different. And miscellaneous plasma cell balanitis azun, cercinate balanitis, the cercinate balanitis and balanitis xerotica obliterans or lichen sclerosis et atrophicus, pseudoepitheliomatous mycaceous keratotic balanitis. So many things are coming and slight difference are there. I will show some picture. So this is balanitis azun. I showed previously erythroplasia of carrot. There it will be more reddish and velvety, but here you can appreciate that orange color tinge. So this is also mostly due to smegma irritation, and usually circumcision will help this individual. Cercinate balanitis, you can see this small circle like thing. So this is more common in Reiter's disease. Reiter's disease is it is characterized by arthritis, conjunctivitis, and secondary due to allergen to chlamydia or some other intestinal pathogens. This is also can produce cercinate balanitis. So this is another commonest thing. Balanitis xerotica obliterans, DXO, is a sequelae of lichen sclerosis atrophicus. What is this? It is not vitiligo. Here, what is the difference between vitiligo and here? Here you can see there will be atrophy of the mucosa, and it is a progressive condition. It may end in tight prepuce and lead to phimosis. It is not a congenital phimosis. And in women, stenosis of the narrowing of the os, and also even narrowing of the urethral opening. All these things can happen. So it is very difficult to manage. Steroids has to be used, or if the stenosis is there, we have to repeat the dilatation, and there is a osteal opening also, it has to be dilated, and the patient may, sometimes it may be progressive. Steroid, intralesional steroid may have some help. And this is another condition called as pseudoepitheliomatous mycaceous keratotic balanitis. It will be respond to 5-fluorouracil. It is a scaly thing, and this also, when left untreated, may go for malignancy. So this is another condition. So these are all things can occur over genitals. And clinical manifestation, as the name implies, there will be signs of inflammation, any balanitis, redness, edema, swelling, pain, irritation, inside crawling sensation. Phimosis secondary to the inflammation is also there. Congenital phimosis secondary to inflammation may occur with the balanitis. And fissuring over the margin of the prepuce. The lesions may vary according to the etiology and localized or total. It may be localized or total. And there may be a burning sensation, subprepucial discharge, fagitating changes may be there. So this is balanoposthitis lead to subprepucial discharge and secondary inflammatory phimosis. You can see the second slide. This is a patient is not able to retract due to the inflammation. Previously he was able to retract. If you treat the condition, the phimosis will be relieved. These infections, subprepucial infection, usually due to Vincent organism or some other spirochetes along with the fusiform. It will be respond to penicillin along with the metronidazole. So if it is not cleaned properly, if it is kept unopened, and secondary infection may invade and produce some this sort of, it is not due to gonococcal infection. It will be offensive, frothy discharge. And predisposing factors, poor personal hygiene, long prepuce, tight prepuce or phimosis, diseases like diabetes mellitus, Wright's disease, Crohn's disease, ulcerative colitis, HIV infection, any immunosuppressive therapy like steroids, cytotoxic drugs, cyclosporin, radiotherapy, endocrinopathies, secondary to genital warts, or this is subprepucial discharge, secondary to genital warts or genital ulcers. All these things can occur. Diabetes mellitus, as Ajay told in the introductory speech, many times the diabetes mellitus was diagnosed by the presence of balanoposthitis, either by balanoposthitis or by vulvovaginitis often. And the commonest predisposing factor for balanitis is the diabetes mellitus. Susceptibility to Candida albicans increases because of the hyperglycemia. In many instances, the presence I told already. Candidal balanoposthitis is the commonest presentation. Here you can see the fissuring. So fissuring is the commonest thing, the margin of the prepuce, and you can see the mucous membrane skin will be slightly greyish and pale. So these are the things. Inflammation also will be there, and reddish glands penis. Sometimes there will be deposit of some white material will be there. It has to be cleaned quite often. So this is some other case of monilial balanoposthitis, which is the commonest thing, and you can see the inflammatory phimosis and fissuring. Other predisposing factor for candidiasis are prolonged oral broad spectrum antibiotics. It disturbs the flora, normal flora, and induces the candida growth. Oral contraceptives, pregnancy, and topical systemic steroids, immunosuppressive drugs, endocrinopathies, infection the partner may lead to these things. Management, total sexual abstinence during the treatment, topical or systemic antifungal antibiotics, control predisposing factor, partner management is if necessary. Severe balanoposthitis is second infection. Anaerobic, I told already, subprepucial discharge. Monilial intertrigo of the child, this is also very common. diagnosis by clinical examination is enough most cases, and demonstration of the organism by KOH preparation, blood sugar levels, rule out other STIs, investigation of writer disease, and confirm biopsy with BXO, erythroplasia, so all these things. Complications, recurrence, chronic reinfection from the partner, phimosis, paraphimosis, preputial adhesion, CA, pigmentary changes. Treatment according to the diagnosis. Prevention, improve the personal hygiene, genital hygiene, control hyperglycemia, and avoid predisposing factors. Just a few slides, 2 or 3 slides. Vulvovaginitis, same thing, more or less. It's more common in children rather than adults because of the pH of the vagina, and also epithelial lining is squamous in the adults. In children it's a single layer, so the vulvovaginitis is more common in children rather than in adults. And so this is traumatic ulcers may mimic vulvovaginitis. This is correspond to BXO, that is lichen sclerosis atrophigus. It is otherwise called as sclerosis vulvae. And candidal vulvovaginitis, same like that. Vulval dysuria. The vulval dysuria, here the patient may complain of dysuria. Here, what is the difference with urinary tract infection? Here, the last part, the dribbling urine causes the dysuria. So, the end of the maturation act, the patient will have this dysuria. In urinary tract, it is not so. So, monilial vulvovaginitis, redness, white deposit, predisposing factors, diagnosis. So, these are the things. Treatment of vulvovaginitis, same thing, and pessaries, systemic antibiotic, all these things. Summary, balanoposthitis in men and vulvovaginitis are quite common in the day-to-day practice. Candida etiology is commonest one. Predisposing factor have to be addressed properly and get good success rate. Without knowing various causes of balanoposthitis and vulvovaginitis, it will be very difficult to suspect or arrive at the diagnosis. Subsequently, it poses difficulty in the management. Female children are more vulnerable. Thank you very much for your patient hearing.
For felicitating Dr. Murugan sir, I would request Dr. Radhakrishnan sir to kindly come on the stage, and I would like the audience to kindly give a round of applause to Dr. Murugan sir for such a wonderful presentation.